We're going to be talking about innate immunity first. This is otherwise known as inflammation, and then we're going to go into adaptive immunity next. People every day are exposed to multiple environment insults. So whether it's microorganisms, a thermal injury, any of that stuff can potentially place the organism, you the human, at risk for disease causing potentially infectious organisms and potential death. So without an efficient system of protection, most individuals would actually succumb quite early in life because there's such a onslaught of microorganisms like all the time. Like, it's so impressive what our body does. So this is otherwise known as the innate, natural, or native immunity. You can refer to any one of those. All three of them are appropriate. The inflammatory response is innate immunity. So what happens is when that physical barrier is broken, we have the response of the body to try and minimize that exposure. The innate immunity system has two lines of defense: natural barrier and inflammation. The natural barriers are physical, mechanical, and biochemical barriers at the body's surface and are at place once you're born. The inflammatory response is activated to protect the body from further injury, prevent infection, and promote healing. We do have possible aberrations here, and you can have some disease processes that are resulted from in problems with your inflammatory response. Main job: protection against microorganisms. If you see Mo's moving forward, and that basically means microorganisms, chemicals, and the environment. Physical barriers: first line of defense, that interconnected epithelial tissues, the skin, GI and GU tracts, respiratory tracts. We have multiple mechanisms that are on that physical barrier that help. The mucosal epithelial cells are highly interconnected. We talked about those gap junctions. These would be those top very tight epithelial junctions at the top, and that prohibit passage of microorganisms into the underlying tissue. The normal cell turnover of these sites actually results in washing away the surfaces, and it actually mechanically removes many infectious microorganisms and prevent residence. As we're going to find out, you have a lot of bacteria that basically live on you. Other ways: coughing and sneezing, vomiting, urinating. So coughing and sneezing, we have that hair-like cilia that mechanically move the mucus upwards and then expel it by coughing or sneezing. We also have mechanical cleansing by vomiting or urinating. And then we have these biochemical ways that we help. And that is through mucus, sweat, cerumen, tears, and saliva. They all basically trap and destroy microorganisms. Some of them, such as your sebaceous glands in the skin, actually secrete antibacterial and antifungal fatty acids, as well as lactic acid. You know, there's all these little cool mechanisms that the body has. The other thing is the low temperature on the skin and low pH of the skin and stomach usually inhibit microorganisms. Microorganisms really prefer warm, and they also like more of a neutral. So our skin does the opposite, and our GI tracts and things like that. The second line of defense is the inflammatory response. This is an immediate response of inflammatory cells, plasma proteins, and fluid. It exits the blood system and gets into the interstitial space and tries to limit the extent of tissue damage, characterized by edema and neutrophils in the tissues. And it depends on chemical components and cellular activity and is non-specific. All right, there is no memory in inflammation. You get poked by a nail one time, inflammatory response is going to do its job. You get poked by a nail another time, it's going to start over from scratch and do the exact same response. It has no idea what microorganisms you got exposed to. This is kind of a schematic of the inflammatory response. So we have that homeostatic condition, which means we do not have any injury. Somehow, let's say we get a nail and it's dipped in manure, so we know that there's little microbes on it. So we have that injury. So then we are going to have inducers of inflammation. We're going to have activation. We're going to have an inflammatory mediator response. We are going to recruit leukocytes. We are going to then recruit anti-inflammatory mediators. If we turn something on, we need to be able to turn it off. We then go into damage repair. So this is where we get wound healing. We return to a homeostatic state. As you see, when we move through all of these things tonight, we're going to be talking about many players in each level of this. So the typical inflammatory reaction develops through a series of sequential steps. We get recognition of a noxious agent that is initiating stimulus for inflammation. The cells involved are tissue-resident sentinel cells, phagocytes, and others. They are equipped with receptors. That's what these DAMPs and PAMPs are. They are going to be able to recognize microbial products, substances released from the damaged cells. All of this is going to induce more inflammation. We then recruit leukocytes, plasma proteins, into the tissues. Since blood perfuses every tissue, leukocytes and proteins such as complement can be delivered to any site of microbial invasion. When pathogenic microbes invade the tissues, the cells die. Leukocytes, mainly neutrophils, later monocytes and lymphocytes, and plasma proteins are rapidly recruited to the area. There is an exodus of cells and plasma proteins from the blood, goes into the tissue area, and that's where we're going to get these fluid and edema and swelling and redness. We get all those pro-inflammatory responses, those mediators. We then will remove the stimulus of inflammation accomplished by the phagocytic cells, ingest and destroy microbes and dead cells. We then have to turn it off, and that's where we get anti-inflammatory mediators, so they're going to turn the inflammatory response off, and then we move into repair. So we have recognition, recruitment, repair. There are cardinal signs of inflammation. We all know these: redness, warmth, swelling, pain. There's actually a fifth called loss of function, meaning that the area does not perform like it's supposed to. The Latin words are in parentheses there: rubor, calor, tumor, dolor. So first thing that we have to be able to do is recognize the microbes and damaged cells. And the way that we do this is by cellular receptors to damage. They are called pattern recognition receptors. They are going to recognize molecules with patterns on antigens or maybe cellular damage. Cells express receptors in the plasma membrane. Those would be for extracellular microbes, the endosomes for ingested microbes, and then the cytosol for the presence of foreign invaders that enable the cells to sense their presence in any cellular component. So we have a couple different locations that these cellular receptors to damage are located. When we're talking about sensors of cell damage, we refer to them as DAMPs, so products of cellular damage, necrosis or apoptosis related. When we're talking about pathogen-associated molecular patterns, we're talking about PAMPs. The PAMPs, there are certain items that are on viruses, bacteria, fungi. Any of those foreign invaders may have glucoses, lectin, mannose. They may have something that's on their cell surface that it's on the pathogen only, and the cell receptors are able to sense that. When we're talking about cellular damage, so this would be cytosolic receptors, such as the node-like receptors. They are intracellular, and they will recognize diverse molecules that are liberated or altered as a consequence of that cellular damage. So when we look at DAMPs, all cells have cytosolic receptors that sense molecules that have been liberated or altered related to cellular damage. So I have a picture of this. So when we're talking about DAMPs, such as node-like receptors are more internalized versus the toll-like receptors, which sit on the cell surface. The damage-associated molecular patterns would be happening if it was in the cytosol, or if we have nucleic damage, all of that. Other things that it may is uric acid, which is released, ATP. There may be reduced potassium levels as a result of plasma membrane injury, and then the DNA it's going to activate this thing called an inflammasome. An inflammasome basically is going to induce the inflammatory response. So it actually recruits leukocytes and is induced by interleukin 1. PAMPs, pathogen-associated molecular patterns. So they recognize patterns on microbes by these receptors and activates the production and expression of proteins. So we have cytokines here, both pro-inflammatory as well as adaptive lymphocyte activation, interferons. Then we have toll-like receptors. So these are present on cells of innate immune system, such as macrophages and dendritic cells. Again, they would be more on the cell surface. Here's your phospholipid bilayer, so it would be sitting on the outside there. And they would activate the pathogen molecular patterns shared by the microbes. There's also a nuclear transcription factor that activates more immune response genes, leading to multiple immune mediators. So these guys kind of sound the alarm. Hey, we have a microbe coming in, or hey, something's wrong with my cell and we have damage going on. So those are how we sense that damage has occurred. We have a vascular response to damage, and this is regardless of what that insult is, it is going to elicit the same vascular response. This is what gives us those cardinal signs of inflammation that we talked about: rubor, dolor, tumor. What happens is it is going to create this arterial constriction and increase vasopermeability, and we're going to deliver neutrophils, plasma proteins, and other mediators into the site so that we can battle this foreign invader. So what does this look like? We have 3 characteristic changes to the microcirculation. So we have that tissue injury caused by a physical, chemical agent, or pathogenic microorganism. So this is basically that nail comes through the skin. We know that it was dipped in manure, so we know there's microorganisms on it. Now what's going to happen? So we originally get vasodilation. It's induced by an action of several mediators, notably histamine on the smooth muscle. It is one of the early manifestations of acute inflammation and involves the arterioles and then leads to the opening of the new capillary beds in that area. The result is going to be increased blood flow, which is causing the heat and redness at the site of inflammation. So here we have that. So we're going to end up with vasodilation. It's quickly followed by increased permeability of the microvasculature. So there's an outpouring of protein-rich fluid into extravascular tissues, pulling apart the endothelial tissue and allowing for the fluid to be released into the tissues. This is kind of a schematic, and we're moving downward. So the next thing is we're going to have that attraction of leukocytes. This is multiple steps. It's called diapedesis of the white blood cells, namely neutrophils, but it's going to be bringing the white blood cells into the area so that it can battle the microorganism. So 3 characteristic changes to microcirculation. 1 is vasodilation, 2, increased vascular permeability, and 3, we're going to get a whole bunch of white blood cells into the area. Look at each one of these individually. So vasodilation, histamine is the main mediator. We have increased blood flow, which is called erythema, and we have heat, which is calor. So there's where those classic signs and symptoms come with vasodilation. Quickly followed by increased permeability. There is an outpouring of exudate into the extravascular tissue. It actually will slow blood flow due to increased blood viscosity, and we get a stasis of the blood flow, and that's called vascular congestion. It brings in the leukocytes and activates adhesion molecules so that we can get through a lot of these next steps. So there's a loss of fluid and increased vessel diameter that leads to slower blood flow. So concentration of red cells in the small vessels, that's what increases the viscosity of the blood. There is the engorgement of small vessels and slowly moving red cells, and that is what is termed stasis. So when we get exudate is basically high protein content, so lots of protein, and may have some red and white blood cells. Then we moved on to increased permeability. So several mechanisms are responsible for the increased permeability of the postcapillary venules. There is retraction of those endothelial cells, resulting in the opening of the spaces. It's initiated by histamine, bradykinin, and leukotrienes. Usually occurs within 15 to 30 minutes of exposure to that injury. In some forms of mild injury, such as radiation or burns, exposures, it can be delayed up to 2 to 12 hours. But usually it happens within 15 to 30 minutes of exposure. And that's that immediate transient response. We also get endothelial injury, and that endothelial damage, necrosis, or cell detachment. So when we're talking about that damage that happens here, such as in burns, severe injury, microbes, toxins that target the endothelial injuries, we can have some changes related to the neutrophils that are adhering to the endothelium. They may also injure those endothelial cells. So that's kind of more direct damage to the endothelium. Direct damage. So this may be why we have varying degrees of increased vascular permeability. So as we know with severe burns, the vascular leakage induced by that mechanism can cause life-threatening loss of fluid. So that is what they believe is the main mechanism. Next up is leukocyte recruitment. So the changes in the blood flow and vascular permeability are quickly followed by an influx of those leukocytes into the tissue. So that's the main thing. We got to get those fighters into the area. The leukocytes perform the key function of eliminating the offending agents. The most important leukocyte of the typical inflammatory reaction are the ones capable of phagocytosis. That is going to be those neutrophils and macrophages. So what happens, the journey of leukocytes from the vessel lumen to the tissue is a multi-step process, and that's what we're going to go through here. We have margination, rolling, adhesion, transmigration, and chemotaxis, phagocytosis, destruction of phagocytosed material, and ultimately resolution. Basically in the lumen, margination, rolling, and adhesion to the endothelium results. So this would be the lumen vessel. Migration across the endothelium and vessel wall. And then we get phagocytosis and destruction of material once we have transmigrated across the endothelial wall. Chemotaxis. So chemotaxis is kind of, you put the balloons out. So, hey, we have microorganisms. We need all kinds of players to come to the party. So it's basically, hey, waving the flag, chemical mediators sending these alarms and saying, hey, this is where the party is. We need you to be in here. So the leukocytes first roll, and then they become activated and adhere to the endothelium. Then they migrate across the endothelium, pierce the basement membrane, and migrate towards the chemoattractants emanating from the source of injury. So first up, we have margination. So this is a process of leukocyte redistribution. They move closer to the cell wall. So if you take a look back here, so this would be your lumen of your blood vessel. So normally they're kind of free floating all over the place. What happens with margination is they begin to move closer to the cell wall, and that means that they're able to detect changes on the endothelium and exposure to these adhesion molecules. All right, so you have these little molecules that are exposed on top of the endothelium, and they include such things as selectins. P-selectins is a big one. E-selectin, protoglycan. There's an integrin, ligand, CAM1. But these are these adhesion molecules. So as the white blood cell rolls over it, then it's going to be activated by these adhesion molecules, and it's going to pull it closer to the edge of the endothelium. So the leukocytes bind loosely and begin rolling on the endothelial surface, and then they come to rest and adhere firmly. So now we're getting kind of closer here, and we have tethering, rolling, and it gets pulled in there closer. Then we have leukocyte adhesion. So receptors are expressed on those leukocytes and endothelium. They bind the sugars such as the lectins. So here is that E-selectin, L-selectin, P-selectin, and you can see the difference there and how long they are. So E-selectin stands for endothelial. P-selectin is on platelets and endothelium. And then L-selectin is expressed on the leukocytes. Typically, if we weren't being activated for the inflammatory response, there are very low levels of P, E, or L-selectin, and they're not expressed on intact endothelium. So if you don't have a break in the endothelium, you're not going to have these show up. They are upregulated after stimulation, meaning like we have injury, these guys are going to start sprouting up so that we can get that leukocyte adhesion. The other thing is integrins. So integrins are other mediators for adhesion. They mediate adhesion of leukocytes to the endothelium and the extracellular matrix. So they're a little bit more deeper rooted, not just on the cell surface. They're going to go down into that extracellular matrix. They are activated by chemokines, are produced at the site of the injury, and bind to the endothelial cell proteoglycans and are displayed as high concentrations on the endothelial surface. So again, they're sounding the alarm, putting the balloons out, putting the banner out, saying, hey, this is where the party needs to be. They then undergo a conformational change, and they let the leukocytes cluster together. There are also upregulations of expression of ligands, so tumor necrosis factor and interleukin-1 for the integrins. Next step is leukocyte migration through the endothelium. So we have transmigration. This is the extravasation of leukocytes through the endothelium. It occurs mainly in that post-capillary venue. So this is not at the beginning of it, it's at the end of the situation. Transmigration of the leukocytes is where there is that maximal retraction of the endothelia in that post-capillary venule. Pierces the basement membrane and moves within the tissue. We have more chemokine signaling for additional movement. Again, chemotaxis is moving it towards the site of injury. So not only do we have the balloons at the end of the driveway, now we have the balloons at the actual site of the party. So we have chemotaxis in multiple areas. So it's bringing the white blood cells into the area, but now we're getting in closer to the area, so we need more chemotaxis to bring it together. Basically moves towards the site of injury even more. There's locomotion against that chemical gradient. So the chemotaxis is a chemical gradient. We have endogenous and exogenous substances that act as chemoattractants, such as the cytokines, bacterial products, complement. Now we're into the area where the microorganism is. So now we're going to have phagocytosis. We talked about this back when we talked about lysosomal. Remember, we had that phagocytosis is one of the options of endocytosis. So phagocytosis also has a few steps. So we have opsonization, engulfment, and fusion. This should look familiar. This is the same thing that we talked about with the lysosomal pathway. So we have the bacterium. We have those receptors. Basically brings it in. We have a phagosome. We have the lysosome that binds to it. We then have a phagolysosome. We end up with breaking down the bacteria. We get those degradation products. The two main phagocytosers are neutrophils and macrophages. So we have opsonization, which is recognition and attachment of the particle to be ingested by the phagocytose neutrophil or macrophage. So this is basically recognition of bacteria. I'm just going to use bacteria. Let's just do microorganism. Engulfment, bringing in, and then we are going to create that phagosome. Fusion, so we have the lysosome and the phagosome, and we get the phagolysosome. And then killing of the microbe and degradation of the ingested material. So the destruction, we can get reactive oxygen species, reactive nitrogen species, and lysosomes. Those are the three mechanisms by which we can get killing of the bacteria. And then number 7 step is destruction of the microbe, which we just kind of finished up there. Number 8, resolution. It is ultimately prevent infection and further damage. It limits and controls the inflammatory process. It will interact here with the adaptive immunity system to elicit response if necessary. and prepare for repair and healing. This is only an immediate threat covering of about 8 to 10 days from onset to healing. So let's take a look at some of the intracellular destruction. So we have that killing of the microorganism by the reactive oxygen species, reactive nitrogen species, and lysosomal enzymes. So we talked about free radical damage, and we mentioned that in the inflammatory response, we have this respiratory burst, or leukocyte burst is what it's called. This is what happens with neutrophils. So what happens here is the reactive oxygen species is produced by the rapid assembly and activation of a multi-component oxidase. So this is this NADPH oxidase. It stands for nicotinamide adenine dinucleotide phosphate. So NADPH for short, for sure, huh? And in the process reduces oxygen to superoxide. So there is oxygen basically being reduced to superoxide. We then have this oxidative reaction triggered by activating signals accompanying the phagocytosis and is called the respiratory burst. So this is happening within that phagolysosome where they can act on the ingested particles without damaging the host cell. The superoxide is converted into hydrogen peroxide by the superoxide dismutase. Hydrogen peroxide is not able to sufficiently kill microbes by itself. However, we have some other enzymes that are involved. That is this myeloperoxidase, and that converts it to hyperchloride, which is the active ingredient in bleach, which is a very potent antimicrobial agent and destroys the microbe by halogenation. So this H2O2-MPO complex is one of the most potent bactericidal system of the neutrophils. So big killing machine with that one. Then we have this other version, which is reactive nitrogen species. Remember we talked about nitric oxide. So eNOS is a potent vasodilator. It's released by the endothelium, and that is what controls your lumen. We also have a neurotransmitter, nitrous oxide, which we're not talking about in this concept. So INOS is activated in microbial killings. So this is, I guess if you want to remember it, is inflammatory nitrogen oxygen species, and that's how you're going to remember it's INOS. So nitric oxide is a soluble gas produced by nitric oxide synthase, which participates in microbial killing. The nitrogen-derived free radicals, similar to a reactive oxygen species, attack and damage lipids, proteins, and nucleic acids of the microorganisms. Remember I said there was another free radical that really did some damage? Well, this was that nitric oxide plus superoxide equals peroxynitrate, which is ONOO. Oh no. And again, it is basically a very potent way that we're going to kill microorganisms. We also have these things called neutrophil extracellular traps, NETs. So they are produced by the neutrophils in response to a microorganism and inflammatory mediators. So here's kind of neutrophil. We lose the granules and nuclear integrity, content mixing, reactive oxygen species. So what's kind of this last effort for the neutrophil is that it releases this viscous meshwork trap, and it provides an additional mechanism to kill the microorganisms. Kind of cool, isn't it? So they've got all these ways that we kill these microorganisms. Also in there is that lysosomal. I'm not going to spend a lot of time there because we know how the lysosomes do since we spent time on that one previously. But remember that lysosomal is in there for that extra intracellular destruction. Another way that we can get some leukocyte-mediated tissue injury. So this is collateral damage. So what happens is we have that inflammatory response, but part of the reaction ends up with some collateral damage. So we get some injury here. So as part of the normal defense reaction against infectious microbes, the adjacent tissues suffer that collateral damage. Some infections are very difficult to eradicate, such as TB or hepatitis. There may be a prolonged host response, and that contributes more to the pathology than the actual microbe itself. So the way that this, no matter what the response is or how it happens, so we have three ways. Can be number one, part of that normal defense reaction. Could be two, autoimmune, where the inflammatory response turns on its own tissues, which is what autoimmune is. And we'll talk about that a little bit later. And then we have this hyperreactive, which is allergic reactions against harmless allergens, environmental stimuli. So regardless of either 1, 2, or 3, however this happens, the leukocyte damage to normal tissue is the same mechanism. Once the leukocytes are activated, their effector mechanisms do not distinguish between offender and host, is basically what happens. So now we're going to look at all the mediators of the inflammatory response. So the mediators are substances that initiate and regulate the inflammatory response. They may be produced locally by the cell at the site of inflammation, or they may be derived from circulating inactive precursors activated at the site. They are macrophages, dendritic cells, and mast cells. Those are like local cell mediators. So let's say here we have our skin, we have that injury. So the local mediators are going to be resident, like right underneath the skin. Okay, so those are those macrophages, dendritic cells, mast cells. Dendritic cells and mast cells are literally like sentinels that are waiting for injury to happen. Then we have the blood system. So then we have circulating proteins that are in the blood, just waiting for the chemokines, just waiting for that injury to be called in, and then we get some action from them. Most mediators are short-lived, meaning they do not hang around for a long period of time, and one mediator can initiate another mediator. So the most important mediators are some vasoactive amines, lipid products, cytokines, and complement. So these would be like histamine, chemokines. We're going to go into each one of these, leukotrienes, and complement. All right, histamine is the vasoactive amine, and it's very important. It causes that rapid vasoconstriction of the large vessels, vasodilation of that capillary bed, which basically gets that increased blood flow to the microcirculation. Results in increased vascular permeability. We have H1 and H2 receptors. H1 is primarily on smooth muscle and is pro-inflammatory and causes also bronchoconstriction. H2 primarily located in the parietal cells in the stomach and anti-inflammatory and suppress leukocyte production. So they actually kind of are involved on the anti-inflammatory side as well. We have arachidonic acid. So arachidonic acid, this is where we get prostaglandins from. So prostaglandins and leukotrienes are from arachidonic acid. So let's understand where they come from before we start talking about them. So we have two different pathways. What happens is we have that break in the endothelial tissue. It's released from the phospholipid bilayer. So this is a lipid mediator. So remember, we have that bilayer. That gets broken, mediators released. Whether it's mechanical, chemical, or physical stimuli or other mediators can also do it from the phospholipid bilayer. But we get a break in there. It releases arachidonic acid, and we get two pathways by which we can get prostaglandins or leukotrienes. The first pathway is the cyclooxygenase pathway, or the COX pathway. This is the one that's going to produce prostaglandins. We have a number of them. Basically, prostaglandins are going to increase vascular permeability and vasodilation, and they're also going to give us pain and fever. The second pathway is 5-lipoxygenase, which produces leukotrienes. Leukotrienes will attract neutrophils, chemotaxis, and they also mediate vasoconstriction, bronchospasm, and increased vascular permeability. What happens then is they bind decoupled receptors and can mediate almost every step of the inflammatory response. So arachidonic acid is high yield and heavily involved in your inflammatory response. So if you look here, so we have the membrane phospholipids. So we have phospholipase A2 releases the arachidonic acid. We have either the cyclooxygenase pathway or we have the lipoxygenase pathway. So this is a nice little schematic for you to see exactly two basic pathways come off of the arachidonic acid. Prostaglandins, they are long chain fatty acids. They are classified by PG and then a letter basically describing their double bonds in the compound. So I have the ones here that are kind of high yield. So PGE1 and PGE2, they will increase vascular permeability and smooth muscle contraction, act directly on that post-venule capillary. Big with that vascular permeability. The way that I would remember it is we have permeability. So E, PGE 1 and 2, lots of increased permeability, smooth muscle contraction, and post-venule capillary. So a lot of E's in there. That's how I remember PGE1 and E2. Next up is PGI2, otherwise known as prostacyclin. This is actually a potent platelet aggregant. So it actually inhibits platelet aggregation, so it's going to decrease platelet aggregation. And it's going to prevent a thrombus in normal functioning cells. So this is just something to understand. If we have prostacyclin, it's going to decrease platelet aggregation. It is an inhibitor, and it will prevent thrombus in normal functioning cells. We don't want a whole bunch of thrombus being produced, right? It's the last thing that we want in normal functioning cells. The other thing that it's going to do is vasodilate, potent vasodilator. Next up is PGD2. So this is made by mast cells, causes vasodilation and increases vascular permeability. It is also a chemoattractant for neutrophils. Thromboxane A2, so this is a potent platelet aggregate and vasoconstrictor. This one promotes thrombosis. So if you have thromboxane A2, you are promoting thrombosis. You are a vasoconstrictor and you are going to help elicit a thrombus to be formed. Here's a nice little kind of breakdown of that. So we have the phospholipase A, arachidonic acid, we get prostaglandin G2 and H2, and then we get these specific, so prostacyclin, thromboxane, prostaglandin E2, F2, there's multiple things. So when we try it all together, these are where our NSAIDs work. So we are inhibiting prostaglandins. So we have COX-1 and COX-2. Aspirin and NSAIDs inhibit COX-1. High dose aspirin, NSAID, and the COXIBs would basically turn off COX-2. So when we are administering any NSAIDs or Celebrex or aspirin, and this is high dose, then it's going to basically turn this off. So we're going to stop that entire process. So we're not going to get prostacyclin, thromboxane, prostaglandin E2, all of that is going to be inhibited. You can see here we have corticosteroids. It actually inhibits up here at phospholipase A. So we would get no arachidonic acid release. Leukotrienes, so now we're looking at that other line. So we just did the COX line, so now we're going to be the lipooxygenase line. So that's the leukotrienes. So leukotrienes are acidic sulfur-containing lipids, just another pathway off of the arachidonic acid. They are also produced in leukocytes, mast cells, by action of lipooxygenase involved in vascular and smooth muscle reactions and leukocyte recruitment. These are known as slow reacting substances of anaphylaxis. So these guys are later to the party. They show up fashionably late. They do produce effects like histamine, but are slower and more prolonged. We have LTA, B, C, and E. They all cause smooth muscle contraction, increased vascular permeability, and there is a possibility that they do recruit neutrophils and eosinophilic chemotaxis. So you see leukotrienes a lot in asthma. So this is actually where we target some of our pharmacologic therapies, because there is intense vasoconstriction and bronchospasm related to their action. Intense vasoconstriction and bronchospasm. Leukotrienes are actually more potent than histamine when we're talking about bronchospasm. And then there is that pathway again. Next up are cytokines and chemokines. So we have a couple different ones. So the cytokines are tumor necrosis factor and interleukin 1 and 6. Tumor necrosis factor and interleukin 1 serve critical roles in leukocyte recruitment by promoting adhesion of the leukocytes to the endothelium and then migration through the blood vessels. So very important there. Both TNF and IL-1 act on the endothelium, and they are going to result in endothelial activation. They are secreted by multiple cells within the immune system, such as lymphocytes, macrophages, leukocytes, also expressed endothelium, epithelium, and connective tissue. So tumor necrosis factor and interleukin 1 are high yield for leukocyte recruitment to areas. The other things are involved in the local as well as in systemic inflammatory responses. So when we're talking about systemic, so we talk about acute phase reactants, interleukin 1, interleukin 6, and TNF are all acute phase reactants. Interleukins, so these are biochemical messengers produced predominantly in macrophages and lymphocytes. They are due to a response and recognition of microorganisms and products or inflammation. So either or. So recognition of microorganisms or products of inflammation. Interleukin 1 alpha and beta are endogenous pyrogens and affect the body's thermostat. So this is actually what is going to produce fever. Interleukin 6 directly induces liver hepatocytes to secrete the proteins needed for inflammation. So when we talk about those complement, that's what this is going to recruit. Complement comes from the liver, and that is that plasma protein system. We're going to talk about that a little bit later. So tumor necrosis factor, multifunctional cytokine, there's what it's secreted by, macrophages, T lymphocytes, mast cells, and capable of inducing necrosis of cells that possess a wide range of pro-inflammatory. So this guy is pretty strong, all right? So it's a big mover, especially when inducing necrosis. It also has effects on lipid metabolism, coagulation, insulin resistance, and function of endothelial cells lining the blood vessels. If secreted in large enough amounts, it will have a systemic effect. That's where we get those systemic acute phase reactants. It induces fever. It's going to bring more pro-inflammatory proteins to the party. It can result in muscle wasting, which is cachexia, and intravascular thrombosis, and that would be like situations where we have prolonged inflammatory infection, cancer situations. They also believe that TNF is related to mortalities that are related to gram-negative infections that get shock. So there are those critical roles of tumor necrosis factor and interleukin 1, which is what I just talked about. Chemokines. So chemokines are those small proteins that act as a chemoattractant. So they are going to attract the players to the party. So they are putting out the balloons. They are small proteins. There are many different ones. We have a whole bunch of receptors. They bind to G-coupled receptors. They induce second messenger, and they are labeled with this CXC, CC, C times 3. So don't worry about that. Just put it in there for completeness sake. They are released from macrophages, endothelial cells, T lymphocytes, and mast cells. They recruit leukocytes to the site of inflammation. Again, chemoattractant. They also are involved in migration of cells in normal tissues and maintenance of tissue architecture. So they do have a role in non-inflammatory responses. Produced in tissues and sometimes called homeostatic chemokines. And they organize various cell types in different anatomic regions within the tissues, such as B and T lymphocytes in the spleen and thymus lymph nodes. Okay, next up are the plasma protein systems. We have 3 essential systems for an effective response. This is kind of, remember what I said, where we're going to have multiple layers, multiple things, but it's all kind of happening at the same time. So this is just another component of that. So we have this protein system within the blood. So now we're moving not at the site of the injury, But now we're into the blood vessel area, and these are actually circulating. They are present in an inactive form, circulating in the blood, and then, chemoattractants will bring it into the area, and then we're going to get activated. They can be activated in early inflammation, but a lot of them do respond to microorganisms. It is involved with what is called a sequential activation, called a cascade. So all three of the plasma systems are a cascade format. Basically what happens is we will have, let's say we have complement C, and then C3 is going to be cleaved, and we have C3A and C3B. So cleaving is basically breaking it in, and we're going to get two different portions off of it. So the smaller protein is biologically active. The larger portion continues to activating the cascade, and it'll make sense as we get into the complement cascade. So here's the three main systems. So we have complement, the clotting system, and the kinase system. So as you can see, they're basically cascades and pathways, and this goes very much more in depth. We're just hitting the high yield items so that you can understand these systems and you understand why they're responding to acute inflammation. Complement to inflammation constitutes about 10% of the circulating proteins. It's synthesized in the liver, comes from the liver. It may destroy the pathogen or activate or assist in all other components of the inflammatory response system. It is one of our most potent defenders against microorganisms. It is antibody antigen activated, and it is called the complement cascade. So let's take a look at complement. We have three pathways by which complement gets activated. Number one is the classic pathway, and that is the antigen antibody complex. So what you need to know here is we have classic pathway. It is mediated by antigen antibody complex. So we have a microorganism. It's the binding of C1 to antibody, IgM or IgG, has combined plus antigen. Okay, so that's your antibody antigen complex. Next up is the lectin pathway. So the lectin pathway is a mannose binding lectin to carbohydrates on the microbe, directly activates C1. So lectin binds mannose on pathogens. So that's a sugar, and lectin is going to bind to the sugar, carbohydrate, on the pathogen. So that's how the lectin pathway gets activated. The third pathway is the alternative pathway. So what happens with the alternative pathway, it can be triggered by either the microbial surface molecule, such as endotoxin, or LPS, which is lipopolysaccharide, and that is a formation that's on the microbe. It's highly specific to microbes, only present on microbes, so that's how it gets activated. Other things such as venom, cobra venom, would activate the alternative pathway, and it's in the absence of antibody. Okay, so other alternative ways of the bacteria activates it. Regardless of what gets activated, 1, 2, or 3, we all converge at C3. Okay, so that's high yield. So classical pathway results in a couple steps in here, but ultimately we get to C3. Lectin pathway, couple steps in here, we get to C3. Alternative pathway, couple steps in here, but we get to C3. You do not need to know these steps, okay? Just know we have 3 different pathways. It goes to C3. They all converge on C3. So C3 needs to be activated by C3 convertase. So remember, we're cleaving. So we have C3, and it's going to be activated by C3 convertase, and we are going to get C3A and C3B. So it is cleaved by C3 convertase to give us C3A and C3B. So C3A is highly involved in the inflammatory response. C3B becomes covalently attached to the cell or molecule where complement is being activated, and it's an opsonization. So what does opsonization mean? So opsonization means that it is kind of going to tag it so that the other parts of the inflammatory response know that that is the guy that needs to be eaten. So it's basically going to tag the microorganism. I'm just going to draw a thing around here. So we're going to opsonize that microorganism so we know that that is what needs to be destroyed. So then we get C3b also goes on to the next step, which we get C5. Then we are cleaved by C5 convertase, and we get C5a, again another mediator of inflammation, and then we get C5b. This initiates the MAC. What is the MAC? The MAC is the membrane attack complex. This is really cool. All right, so we opsonize the microorganism. So we are tagging it for destruction. Now we are going to initiate the destructor. The membrane attack complex is C5b, C6, C7, C8, and C9. It is a terminal pathway, meaning it stops here. There's no other complement. What happens is the MAC goes over here and basically blows up the microorganism. Gone. Membrane attack complex. Really cool. So regardless of what way that we get activated, we ultimately end up with the microorganism being blown up by the membrane attack complex. Key terms you need to know. 1, 2, 3, your pathways. C1 is the one that we start with on all of them. All right, so C1. You do not need to know these intermediary steps from C1 to C3. So C1 to C3, C3 convertase is going to cleave. We get C3a and C3b. C3a is going to be involved in inflammation. C3b, opsonization. Opsonization means we're going to tag the microorganism. We then go to C5. C5 convertase is going to give us C5a and C5b. These are also involved, C5a in inflammatory response, and then C5b initiates MAC. When we're talking about inflammation, we are recruiting more leukocytes. So chemotactic factor complements main function. We are going to get anaphylactic activity resulting in mast cell degranulation. So what happens with C3a and C5a, that's that inflammatory response that was labeled, right? It is going to release the granular contents of the mast cell, release histamine, causes vasodilation, and increased cap permeability. So this would be the C3a and C5a. We have leukocyte chemotaxis. And remember that a chemotactic factor is a biochemical substance that attracts leukocytes to the site of inflammation. Opsonization, tagging the microorganism for destruction. Cell lysis, that's that membrane attack complex, and we are going to basically blow up the microorganism. The way that it does this is it actually pokes holes into the microorganism cell wall and then influxes water and ions in there, and then it goes. Next up is the coagulation cascade. So now this may be activated by multiple different pathways, but they also converge on the same end product. We have two pathways. We have the intrinsic pathway and the extrinsic pathway. We're going to talk about this a lot more when we get to clotting and coagulation in hematology lecture. I'm not going to spend a lot of time here right now for inflammatory response, but know that it gets activated. So the clotting system is obviously we have that damage to the endothelium. We got to clot it off right away, right? So we can't bleed out. So it does get activated at the initial site of injury at the initial time. What happens is we get blood vessel injury. We activate a couple different factors. This is the clotting cascade. We ultimately get fibrinogen, and we form a blood clot to stop bleeding out. That is all that you need to know at this time for the clotting cascade, coagulation cascade. We will talk about it a lot more when we get to hemostasis. The next system is the kinin system. So this is the production of bradykinin. So back here again, so we get prekallikrein, kallikrein, kininogen, and then bradykinin. So bradykinin is also gives us histamine-like effects. We get more increased permeability, and we also get pain related to that. So we get ultimately bradykinin. So we convert kininogen to bradykinin. Bradykinin is going to result in vascular permeability and smooth muscle contraction and pain. This also interacts with the coagulation cascade. Remember how I said these things are interdependent? They're all part of layers of their response. So this augments inflammatory response in multiple ways. Dilation of those blood vessels, acts with prostaglandins to stimulate the nerve endings to give us the pain, and then also causes smooth cell contraction and may increase leukocyte chemotaxis as well. Interacts with coagulation cascade, the Hangman factor. Brief synopsis of what is going to promote inflammation versus anti-inflammation. Remember I said if we have a way to turn it on, we have to have a way to turn it off. So our promoters of inflammation, PGE2, PGI2, thromboxane, and leukotrienes. Anti-inflammatory, so we have a couple different ways that we turn it off, and lipoxin is one of them. So what is lipoxin going to do? It's going to inhibit neutrophil chemotaxis, so it's going to turn off the alarm system. It is going to reduce reactive oxygen production. It is going to stop synthesis of pro-inflammatory cytokines. It is going to promote macrophage policing of the areas of battle. They basically are going to consume the debris, damage neutrophils, and counter effects of histamine, and they are anti-inflammatory. Resolvins are going to decrease the production of pro-inflammatory cytokines. They are anti-inflammatory. Histaminase, carboxypeptidase, and plasmin also assist in turning off the pro-inflammatory response. And the resolution is, so what's going to happen here? We have a couple different ways this is going to end. Acute inflammation and chronic inflammation are purely related to time. All right, chronic inflammation is greater than 2 weeks. Sometimes we get chronic inflammation if we have an unsuccessful acute phase, which is the acute inflammatory response. Or we're going to change over to lymphocytes for more of an adaptive immune response and cell-mediated immunity. So that is basically moving towards chronic inflammation. If we won the battle, then we're going to progress into wound healing, and we're going to get connective tissue replacement either by scarring or fibrosis, and we will make the area new again. A couple different things to talk about are differences with adult, elderly, and pediatric immunity. Neonates, they have transiently depressed immune systems. It may work one day, may not work well the next day. They are partially deficient in complement. It takes a while for these to be manifested by the pediatric liver and getting those systems in place. They will develop severe sepsis and meningitis with an infected agent not conveyed in maternal immunity. This is why in those first 6 to 12 weeks of life, it is very important that we make sure any fever is identified and taken care of. They have a low level of mannose binding lectin, so that's in that complement pathway. Some infants do have deficiency in collectins, and that is especially true in preterm, and that's where we see this increased risk of respiratory ailments. In the elderly, so what happens with this is we have altered tissue environments from aging, also chronic diseases, and there is delayed wound healing and inflammatory response. We have immunosuppressants, which basically means our immune system declines over time. They also have increased susceptibility to certain infections, especially lung, skin, and urinary. There's a loss of subcutaneous fat, and elastin lessens protection, and then we have easy access for that barrier to be broken. We have a loss of toll-like receptors. We have alterations in T lymphocytes and natural killer cells, which we're going to get into next in adaptive immunity. We also have more pro-inflammatory cytokines as we get older. So we like to be more inflamed as we put the years on. All right, so now let's put it all together. So we went over the components, the mediators, the pathologic manifestations of acute inflammatory response. Now let's put it all together. So the host will encounter an infectious agent such as a microbe, dead cells, resident phagocytes, and phagocytes are also recruited from the blood, try to eliminate these agents. Break tissue injury, trauma, invading microbes, exogenous chemical signals. So we get the phagocytes, and the host cells react to the presence of these foreign invaders, and they start liberating cytokines, lipid messengers, and other mediators of the insult. Some of these mediators are going to act on the blood vessels in the vicinity and promote the influx of plasma proteins and the recruitment of circulating leukocytes. The recruited leukocytes are activated by molecules derived from the microbes. Injured cells locally produce mediators. The activated leukocytes will try to remove the offending agent by phagocytosis. As the injurious agent is eliminated and anti-inflammatory mechanisms become active, the process subsides and the host returns to a normal state. The vascular and cellular reactions account for the cardinal signs of inflammation, which is rubor, calor, tumor, dolor, and functionalesa, which is lack of function. We get increased blood flow to the injured area. Increased vascular permeability leads to the accumulation of extravascular rich fluid, known as edema. The redness, rubor, warmth, calor, and swelling tumor are caused by the increased blood flow and edema. Circulating leukocytes, initially predominantly neutrophils, adhere to the endothelium via adhesion. The adhesion molecules, they transverse the endothelium, migrate to the site of injury under the influence of chemotactic agents. Leukocytes are then activated by the offending agent and by endogenous mediators, and release toxic metabolites and produce proteases extracellularly, causing tissue damage. Due to the damage and the liberation of prostaglandins, neuropeptides, and cytokines, one of the local symptoms will be pain. Loss of function results from pain and injury to the tissues. So there is the gist of it. So we went through all of these steps and we will have resolution. We either go to chronic inflammation or we go to wound healing. So chronic inflammation may be an extension form of acute inflammation or may arise without an inflammatory event. So de novo means without any precursor. It can be caused by persistent infections, hypersensitivity disease, prolonged exposure to toxins. This would be bringing more mononuclear cells, macrophages, lymphocytes, plasma cells, and then we may also have tissue destruction and poor attempts at healing. So chronic inflammation, so we have these polymorphonuclear cells, neutrophils, eosinophils, basophils, lymphocytes, monocytes. They may come more to the party in the chronic inflammation. So macrophages. So we talked about these guys kind of sitting underneath the surface and kind of waiting for the acute inflammatory response, and involved heavily in the phagocytosis. So they are the cleaners. They also are involved in resolution and healing. They continue active inflammation. They may make an abscess or are involved more in chronic inflammation. They remove old debris and damaged cells and large molecular substances from the circulation, and then also involved in tissue repairs. They are dominant in chronic inflammatory reactions. Macrophages are really dominant here. They also contribute to the reaction by secreting cytokines and growth factors acting on various cells. So they'll be present in about 2 to 3 days after the inflammatory neutrophil response. Higher concentrations are in adaptive immunity and chronic inflammation. They are from monocytes in the blood. They will eliminate microbes, particulate matter, and senescent cells. They secrete the cytokine and growth factors, like I said. ingest organisms via phagocytosis and destroy using the lysosomes. Remember, we're making the phagolysosome. And that material in the secondary granules. That's that O2 independent killing, that respiratory burst. They activate other cells, especially T cells, which we're going to be talking about for adaptive immunity. They are activated by two pathways, the classical pathway and the alternative pathway. The classical pathway is induced by microbial products, such as endotoxin. Endotoxins are released from microorganisms and they cause direct injury. The second pathway is the alternative pathway, and those are activated by cytokines, T lymphocytes. So after activated by one of these two pathways, their outcomes will be eliminating injurious agents and then initiate wound healing, or they continue acute inflammation, or they create an abscess. Lymphocytic role in chronic inflammation. So we have activated B and T cells amplify and propagate the inflammation. We're going to get into this next in adaptive immunity. Just be aware of this for chronic inflammation. So we have CD4 plus T lymphocytes. They promote inflammation and influence the inflammatory reaction. There's three subsets of T lymphocytes, and they are T helper 1 cells. So TH is T helper. That's what it stands for. So T helper 1 cells produce cytokine, interferon, and that activates that macrophage via that classic pathway, which we just talked about. T helper 2 cells secrete interleukin 4, 5, and 13, and they're going to recruit eosinophils and are responsible for the alternative pathway. T helper 17 secretes IL-17 and other cytokines, which are chemokines bringing neutrophils into the reaction. Like I said before, we have a lot of interdependent play from multiple agents involved in this. And hopefully after we go through both innate and adaptive immunity, it will all make a little bit more sense. So here is what it looks like with the CD4 plus T helper cells. If we get these activated CD4 T cells, there's tumor necrosis factor, interleukin 17, chemokines, we get macrophages. They kind of all interplay off of each other to activate macrophages, bring T lymphocytes to the party, and get that defense going. Eosinophils, these are responding to more allergic or parasitic infections, and they respond to mast cell activation and basophil chemotactic factors. They will ingest antigen antibody complexes via those PRRs. They also contain inflammatory enzymes, histaminase. Remember, that's anti-inflammatory. And they also release prostaglandins, leukotrienes, platelet activating factor, and cytokines. Their secondary granules have toxic chemicals. They are highly destructive to parasites and viruses. What happens with chronic inflammation is we have these granulomatous inflammation responses. So these are formed with collections of activated macrophages and T lymphocytes. They are characterized by a granuloma, which is epithelioid histiocytic cells, basically macrophages, giant cells, and a rim of lymphocytes. They are associated with central necrosis. It is basically our body's attempt to contain the offending agent, which is really problematic to eradicate. We have two types of granulomas. We have an immune-mediated one, and we have a foreign body granuloma. Two types, non-caseating and caseating subtypes. So non-caseating means it lacks that central necrosis. So that would be a reaction to foreign material, sarcoidosis, beryllium, Crohn's disease, cat scratch fever, cat scratch disease. If you have a caseating granuloma, it exhibits central necrosis. That is characteristic in a tuberculosis infection or a fungal infection. Systemic signs of inflammation. So this is that fever, leukocytosis, and acute phase reactants. So now we're moving into, we have that acute phase we'd have those systemic signs of inflammation. Resolution is hopefully we're winning the battle. If not, we're getting really into adaptive immunity or we're going into wound healing.